Now, today we'll be talking about insulins or insulin. Now, we must know that insulin is synthesized from beta cells of pancreas. We must know that alpha synthesizes the glucagon, which is very important hormone for increasing the glucose in the blood, whereas beta cells they secrete the insulin, which is to uh, dispose of glucose from the blood into the tissues. Now, we have insulin secretion in the blood in two forms, that is, in basal form and bolus form. So, basal, usually 1 unit of insulin is secreted every hour, and bolus insulin is secreted wherever we take meal. So, wherever we take lunch, wherever we take dinner, wherever we take breakfast, that times there is sudden increase in the food intake of in the body, so to dispose the large quantity of glucose or other calories that we have taken in, a bolus form of insulin secreted, whereas when we sleep, at that time the glucose disposing mechanism is carried out by the basal insulin. So insulin in the blood is secreted by cholinergic as well as adrenergic beta 2 secretion. So this cholinergic insulin secretion is by acetylcholine by muscarinic activation, or the vagus nerve causes insulin secretion, and the adrenergic beta 2 stimulation increases the insulin release. Now, what is the action of this insulin? The main action of this insulin is to dispose of the meal derived glucose, amino acids, and fatty acids, so that it favors the storage of glucose as fuel reserve. That is, this glucose actually converts this glucose into glycogen, into lipids, into proteins. So, in short, it is to build reserve of fatty acids, of proteins, to as well as glycogen. So that is the reason why it actually helps us to have stores of glucose as fuel reserve in the body. And the skeletal muscles and fat, they are highly sensitive to the insulin. The entry of the glucose into liver, brain, RBC, WBC, and renal medulla is independent of insulin. They don't need insulin for the entry of glucose. Whereas for the muscle, skeletal muscles and fat, they are highly sensitive to the insulin. The muscular activity, whenever a patient does physical exercises activity, that automatically induces glucose entry into the muscle cells without the need of insulin. That is how physical activity exercises always and always increase the insulin sensitivity by reducing the glucose load in the blood. So in short, insulin, it increases the glycogen synthesis. It inhibits gluconeogenesis from fat and protein. That is how it inhibits catabolism. It inhibits weight loss. It also inhibits lipolysis. That is how it reduces weight loss and promotes weight gain. Insulin, it increases the clearance of VLDL chylomicrons, and it increases the protein synthesis from amino acids. That is the reason why insulin acts as an anabolic hormone. It acts as an anabolic hormone. Now we have different types of insulins. I'll be going through them very shortly. First one is regular insulin, which is very commonly used. It is short acting. Why it is short acting? Because it acts for 6 to 8 hours. That is the reason why it can be kept 3 times a day. 3 times a day, so that it is given every 8 hourly. So before breakfast, before lunch, and before dinner. The onset starts within half to 1 hour, and the peak action of this regular insulin is at second to third hour. So it is usually given thrice a day. Most of the hospital use regular or insulin atrapid, which is this regular insulin. It is extensively used almost in all the hospitals. Whenever it is given subcutaneously, there is tendency to cause early postprandial hyperglycemia, because whenever patient eat, this regular insulin is taken, but it takes some time for that insulin to act and to control the blood sugar. That is the reason why immediately postprandial, the sugars will be high, and it has tendency to cause late postprandial hypoglycemia because this insulin keep on acting till 6 to 8 hours, and by that time already glucose levels have come down. So glucose already comes down, but still insulin is working there at 6th or 8th hour after taking food. That is the reason why it has tendency to cause late postprandial hypoglycemia. It is usually given around 10 to 20 minutes before the meal. It is compared to very, very cheap compared to other ultra short acting insulin. That is the reason why the regular insulin is very much commonly favored, because it is very easily available at most of the places, and it is cheaper compared to ultra short acting insulin. Now, other insulin analogs are actually, these are derived from recombinant DNA technology, and they have very much better stability and consistency as well. Of which insulin lispro is an ultra short acting insulin. Why it is ultra short? Because it acts, the onset starts within 20 to 30 minutes, where it was acting at 30 minutes to 1 hour. The peak of this Lispro insulin is at 1 to 1.5 hour. Here it was 2 to 3 hours. So it is acting very fast, it is peaking very fast, and it is only acting for 3 to 5 hours. So the chances of the this early postprandial hyperglycemia is much lesser, and late postprandial hypoglycemia is much lesser. So it is actually one of the very good component of bolus regime. It is the same way our body acts. Whenever we eat, there is surge of insulin. The same way this Lispro acts, it comes very fast, peaks very fast, and it only acts for 3 to 4 hours, and it disappears from the blood. So it controls the mealtime glycemia very, very well, and it lowers the incidence of late postprandial hypoglycemia. And as this is this has very less duration of action. Usually, more number of pricks are needed. Most of the time, this fasting prick has to be taken, pre-lunch has to be taken, and pre-dinner. So usually around 3 needle pricks are required for this injection Lispro. This is almost same for regular insulin as well. Patient may be on twice, 2 needle pricks maybe before breakfast or before dinner, or patient may be on 3 needle pricks, that is before breakfast, before lunch, and before dinner. So this is one of the best for mealtime glycemia and with lower incidence of late postprandial hypoglycemia. And as I told, it works as a bolus insulin, and it doesn't work as basal insulin at all. Now, other examples of ultra short acting insulin is injection glulicine, which is seen with injection Apitra, injection Lispro, which is seen in injection Humalog, injection Aspart insulin, which is seen with Novolog or Novorapid or Novomix. And the third insulin is injection Glargine, which is actually long acting insulin. The onset starts within 2 to 4 hours of injection. It acts for around 24 hours, so it is kind of a basal insulin. So it is there always in the blood. It usually never peaks, so we call it as a peakless insulin. So it keep on reducing the basal sugar level to a lesser and lesser level. It is very long acting. It is acting for 24 hours, and it is actually biosynthetically prepared, so it provides actually background insulin action, and it doesn't work as bolus. It works as a basal insulin, just like our normal basal insulin, which is synthesized and secreted by our body. So fasting and interdigestive blood glucose is lower irrespective of the time of the day, so we can the injection glargine can be given at any particular time in the day, but most of the time it is given at night before dinner. And this glargine is works as a basal, So always, most of the time, this is always combined with a bolus insulin injection that can be regular insulin, human insulin, or that can be ultra short acting insulin. So it is then called as bolus plus basal insulin regime. The problem with the insulin is hypoglycemia. Insulin can definitely cause hypoglycemia that can be very much serious. Less than 70 milligram per deciliter, we call it as hypoglycemia. Most of the time, patient develop this sweating, palpitations, uneasiness, hungriness. They are very much hungry, sweating, and restlessness. This can be the symptoms of hypoglycemia. Less than 40, it is very severe, and that time patients may have neuroglycopenic symptoms, patient may have syncope, patient may also have convulsion, and these symptoms are very bad. So these are very common symptoms of hypoglycemia, especially if the patient is CKD, that is chronic kidney disease. As we know, insulin gets excreted or removed from kidney. So in CKD, the damaged kidney cannot filter out the insulin outside. So there is increased insulin levels in the blood. So the even if the patient receives lesser units of insulin, patient may land up into hypoglycemia. And the most important thing is key patient, if he's on hemodialysis, undergoing hemodialysis, and if he gets into hypoglycemia, patient can have arrest also. So all the patients who are undergoing hemodialysis must be checked for every hourly BSL till the dialysis is done. So this was all about the insulin for today. Thank you.